I'm Christopher Bellonci. I'm a child and adolescent psychiatrist at Tufts Medical Center, and I was asked by the planning committee and Laurel to talk about the role of the residential treatment workforce in this larger conversation. And thank you for inviting me to do so. I've been struggling since the panel yesterday of parents on talking about a relatively small part of the service array, when I feel like we may be missing a discussion of the greatest challenge to enhancing the children's behavioral health workforce more globally, and that's the will to make it happen. I actually think that one of our greatest levers is moral outrage. And if you'll indulge me, I'm going off script here. Nelson Mandela said that there can be no keener revelation of a society's soul than the way it treats its children. Rebecca, you shouldn't feel like you won the lottery in finding an appropriate evidence-based practice for your child. And it's outrageous that those that weren't that fortunate are being asked to pay $5,000 out of pocket for an evidence-based practice to serve the behavioral health needs of your child. Breck, I don't think you're here, but your family and you shouldn't have to discover after your son develops symptoms that your family would benefit from support to cope with Bennett's cystic fibrosis diagnosis. Robin, are you here? You shouldn't feel ashamed to push the behavioral health floor elevator button. And in fact, you shouldn't have even had to go to the behavioral health floor. Those services should have been provided in the hematologist's office. It should be no surprise to us that your sons are going to have significant pain associated with their sickle cell disease. That should have been anticipated and provided seamlessly without your having to navigate that system and feel shame in doing so. We aren't doing what we know is needed. I think the science is critically important, but we actually have sufficient science to show what evidence-based practices can do, and even better, what prevention science can do. The work of this committee has done significant advancement in our understanding of the power and the return on investment of these prevention methods. You know, when the vice president, a good and fine man, lost his son to brain cancer, the federal response was to call for and propose a moonshot to cure cancer. Why not a moonshot to prevent children's behavioral health disorders? You know, Congress had to pass a Mental Health Parity Act. What other field of medicine needed a parity act? Do we have an orthopedics parity act? A heart disease parity act? Why do we accept this as the condition, the norm? You know, there was a slide yesterday talking about the declining health rates of major diseases, with suicide rate continuing unchanged. Well, in fact, for adolescents, that suicide rate is going up. It's now the leading cause of death for this age group. Who here hasn't been impacted by having a family member with a behavioral health disorder? We're talking about rates of 1 in 5 children developing a behavioral disorder in their lifetime. My niece has an eating disorder. I have a nephew with ADHD. This impacts all of us, and I think it's critically important that we leverage those stories to affect the kind of change that we want to see in our society. We're a resource-rich country. It doesn't have to be this way. I've already mentioned that we have prevention and intervention approaches that work. The slide about workforce shortages, you would think that that would encourage people to flock to this field, right? There's all that need. It's an untapped market. You know, we have a society that doesn't tell people what jobs they have to take. We have market forces that drive people to job openings. The problem with that slide is that those don't actually represent job openings. They represent an unmet need But those aren't actually jobs that people can flock to, because those jobs aren't being created because we're not resourcing them. Why does the child care workforce get such low pay that those providing frontline services are often eligible for Medicaid? So what would a society that truly cared for its most vulnerable members look like? Now, this is the part where I get called naive and pie in the sky. But what if we had a legally binding document like an IEP for children's behavioral health disorders? So just envision what that might look like, those of you who are familiar with an individualized educational plan. We have a right to a free and appropriate public education in this society. Why don't we have a similar right to appropriate children's behavioral health services? In such a world, when a child displays a behavioral health disorder, they would undergo a standardized assessment, similar to what happens when a learning disorder is identified. The standardized assessment would determine their treatment needs, and that would drive a treatment or service plan with measurable goals. A service grid identifying who will do what. A case manager appointed to monitor the service plan. An annual review on the response to these interventions, and a triannual repeat testing assessment. Where would the money come from? It's unrealistic. It's undoable, particularly in this political climate. I know that many here are concerned about just keeping the services and supports that we've fought hard for and achieved, essentially playing defense. And they have little hope or expectation of advancing the children's behavioral health service delivery system. I don't think we should accept that. I think that in addition to the science that this committee has been doing for many years, I would just remind us that perhaps moral outrage may be our greatest lever if we choose to use it. So I was supposed to talk about the Residential Treatment Service Act. Thank you. Thank you, I appreciate that. It just didn't feel like what we're doing in the residential world, or the fact that there's no career path for people working in residential treatment settings who just want to actually work day in and day out with children with severe emotional behavioral disorders, so significant that they can't live at home, that there's no career there. So I don't know how to talk about that topic. I did prepare some slides. According to this, I have an unrealistically large amount of time, which I'll keep going if they keep giving me time. So I guess I can still run through those slides quickly. So these are, I'm used to presenting in forums where you have to disclose your affiliation. So these are some of the things that I do. I was asked to give this talk based on my work at the Association of Children's Residential Centers. I'm actually working with an international group trying to both define the role of therapeutic residential care, what is it, in order to then begin developing data on outcomes, because we have very little data on outcomes of a service area that eats up significant parts of the federal and other behavioral health dollars. So that's really untenable to continue. But therapeutic residential care involves the planful use of a purposely constructed, multidimensional living environment designed to enhance or provide treatment, education, socialization, support, and protection to children and youth with identified mental health or behavioral health needs, in partnership with their families, and in collaboration with a full spectrum of community-based formal and informal helping resources. These are some of the potential levers of change. At the time I left outrage off of this. And these are some examples. So SAMHSA worked with a group of foundations and parent advocacy groups and youth advocacy groups in this initiative called Building Bridges, which was really meant to bring the community mental health world and the residential treatment provider world together, because they really weren't playing in the same sandbox. And in fact, there was a lot of consternation, particularly from community mental health providers, about residential treatment and the way that they've served families and youth. It was a challenging first meeting. There's been several since, where it wasn't clear that we were going to come to a consensus about whether or not residential treatment should even exist in the service array. This is very small print, but there is a website that was developed, Building Bridges for Youth, referenced below, that goes into a lot of the strategies. There was a consensus statement. There's been needs assessment around providing agencies a path to ensuring that they are consistently meeting the Building Bridges resolution, and what specific approaches, incorporating a lot of system of care and CAST principles into and embedded within residential treatment. Another lever within the residential world is the service system and national and industry organizations. I'm very proud of the work that ACRC has done in their Redefining Residential series starting in 2005. They've written a series of white papers talking about the need to become family-driven, redefining the role, transformation through licensing, a lot of the things that we heard about throughout these 2 days. Using performance indicators, and then moving more into trauma-informed care and the rational use of psychotropic medication, serving LGBTQ youth in residential treatment, et cetera. Foundations have been advancing our work in thinking about how to appropriately use residential settings within the larger service array, Casey Family Programs, A&E Casey Foundation, Jim Casey Youth Opportunities. I've worked with all of them in various forms. Promoting best practices for mental health and child welfare consensus conference, coming out with a toolkit. There's a practice pathway tool for transition age youth that Jim Casey Youth Opportunities developed. A recent Casey Family Programs brief on elements of effective practice. So I think that partnership with foundations in advancing best practice is one that we need to be considering and tapping. Accreditation entities, we had a whole panel yesterday. These are some of the ones that accredit residential facilities. They've really been helpful in advancing a number of best practice approaches within residential treatment, including improving standards of care around seclusion and restraint. There's interesting private agency and university partnerships. So most residential programs don't have funding or resources to do their own outcomes research, but partnering with a university is a great model, and one of the evidence-based practices that came out of residential treatment, the teaching family model, which is a component of Boys Town. And then, we heard from Johanna and Youth Move about youth engagement specialists. There's actually a Youth Move chapter embedded in a residential program in Oregon. So thinking about using youth engagement specialists within this service array can be very powerful. And then we've heard from Millie and about the work of Fredla and the work of the Federation. And I think, again, returning to my original comments, the opportunity and the importance of leveraging both the youth voice and the parent voice, I think is the path to our future. The president-elect's daughter helped to put subsidized childcare on the political agenda. There's no reason that we can't continue to take that initiative and expand it to talk about the issues that we care about. And then just finally, remembering that faith-based programs and partnerships, we actually had to think about employment at the residential program that I was medical director of for many years as a faith initiative, in part because we couldn't pay people, and it's not because we were tapping their faith so we could pay them less, but it had to almost be a spiritual endeavor. because it's not something that was being valued either economically or in many other ways in our society. So these are some of the resources that I quickly ran through, and I managed to end on time.